Today we'll be talking about valgus overload instabilities. The bony anatomy of this is the radius, ulna, humerus, medial and lateral epicondyles, trochlea, capitulum, and olecranon process. The ligaments of this joint is the joint capsule, annular ligament, ulnar collateral ligament, and radial collateral ligament. The ulnar collateral ligament is the one that we will focus on in this topic because it is on the medial side of the elbow. Carrying angle is something that we all use on a daily basis, but you may not realize. Extension of this is 0 degrees. Males can have an extra 5 degrees, whereas females can have 10 to 15 degrees. Flexion is 145 degrees active, 155 to 160 degrees passive. Your elbow triangle is when your elbow is flexed, the olecranon process, medial epicondyle, and lateral epicondyle all form an isosceles triangle. Acute injuries are caused by lateral trauma, but it is very rare to have this without any underlying chronic issues. A chronic issue is when you have an underlying issue or injury that causes laxity in your ulnar collateral ligament, which allows for partial to full tears of the ligament during cocking and acceleration phases of the throwing mechanism. The main mechanisms of injury for this are cocking phase, acceleration phase, and then direct trauma to the lateral aspect of the elbow. Signs and symptoms for this are pain. The patient can't throw as far as they used to. They hear or feel a pop while they're performing the action. Osteophytes or bone spurs on the olecranon process. They could have gunstock deformity, which is when your carrying angle is changed and your arm protrudes towards the midline, or you can have cubitus valgus, where your carrying angle changes so that the arm protrudes laterally. The special tests for this are the moving valgus stress test, and valgus extension overload test. Predisposing factors for this condition are competing in throwing-based sports such as baseball, softball, or javelin toss and track. You have previous injury to the elbow, or you have muscular imbalance. Some differential diagnosis is flexor pronator mass tendinopathy, ulnar neuritis, and medial epicondyle apophysis in skeletally immature patients. Management for this would be a referral. You would immobilize it, surgery if needed, and then therapy to fix it. You would refer so that you could get an x-ray or an MRI to make sure that there are no fractures, and the MRI to make sure that the ligament is still intact, or if it has been torn and you need to go through with surgery. You would immobilize it with a sling or splint. To help prevent this, you should strengthen your surrounding muscles, fix any improper mechanics you may have, and avoid repetitive throwing motions. There are two mulligans for this, where you would laterally glide the elbow joint with slight external rotation of the humerus, or you can try medially translating the olecranon process while stabilizing the distal medial aspect of the humerus.